And the title of the article is Value-Based Payment and Vanishing Small Independent Practices. Hey, welcome to another episode of the Better Outcomes Show. I'm your host, Rafi Salazar with Rehab U Practice Solutions. And this is the first time we're recording in 2025. Hopefully you all had a wonderful holiday season. I personally spent some time with kids, with the family from out of town. It was great. Took some time off, did some reading, and that's what I want to talk about today. So hopefully this will be one of the last solo episodes we do for a while. We've been busy behind the scenes scheduling a whole bunch of interviews. We're going to do a series on data for clinical decision making. We'll do a series on data for the business side of things, showing ROI in like maybe technology investments and things like that. And then we've got a couple guests coming on that are just doing interesting things in the world of technology-enabled care, cutting edge new treatments that are coming out according to literature and stuff like that. So excited about what 2025 has in store. This week, though, I do want to talk specifically about this idea of healthcare consolidation. I know we've talked about it a little bit here and there on some different episodes. It's been kind of in the background. It's probably one of those underlying currents for the last several years in healthcare. It's kind of made its way more and more to the forefront, climaxing probably at the end of 2024 with the when the murder of UHC's CEO happened. A lot of things that were coming in the news afterwards were really about quote unquote big healthcare, the evils of big healthcare, and how all these companies continue to get larger and larger, and they're not good for public health or for individual patient outcomes and stuff like that. So one of the things that I took time to do over the last few weeks that I was off during the holiday season was read a couple articles and catch up on kind of what's going on trend-wise. You know, you always are aware healthcare is so big that I find very often that I end up, because of the work that I do with healthcare technology startups and innovative healthcare companies in the musculoskeletal space, that a lot of my focus, a lot of the conversations that I have, a lot of the trends that I see tend to be very much specific and specified to that kind of musculoskeletal care arena of healthcare. But even though some of those larger trends kind of transcend and go to all the different specializations and verticals within healthcare, that's kind of where I spend a lot of my time, are companies that are in the musculoskeletal space trying to do cool and innovative things, try to humanize healthcare in that regard. So what I like to do when I have some time, some headspace, is just kind of poke around through my professional network. Maybe it's through LinkedIn, maybe it's through people that I've connected with at conferences or worked with on other consulting projects, and kind of see what they're into, so to speak, what they're concerned about, what they're writing about, what they're publishing about, what they're researching about. And one of the articles that popped up that was in my feed a lot, a few of my colleagues and connections shared this, were commenting on this, was this idea of value-based payment on the horizon. We know it's coming, but is it going to be too burdensome, and will it drive the elimination of independent private healthcare practices? So the article, and I'll link to it in the show notes, Journal of the American Medical Association. Let me see when it was published here. I don't have, it was 8/28. So in August of 2024. And the title of the article is Value-Based Payment and Vanishing Small Independent Practices. Now, I've mentioned the consolidation in healthcare from a few different angles. I'll link to a couple of those interviews where I discussed it a little bit, specifically in the physical therapy industry. I was on the Strata Studios podcast with Paul Singh, and we talked specifically about independent healthcare practices, private physical therapy practices, and what they can do to combat or to compete against larger healthcare organizations, or at least the challenge that small healthcare practices have when in a market dominated by large players. I think the example that I used was in my city of Augusta. We've got 4 hospitals, 5 technically if you consider the Department of Veterans Affairs. And with the exception of the government hospital, all of the other hospitals are now owned by large, I would consider them large corporate healthcare organizations. You know, HCA, Piedmont, Wellstar, they own all of the hospitals. So that means not only are the hospitals private, but they've gone kind of acquiring other areas to kind of, you know, increase their footprint. So they've purchased physician practices, they've purchased physical therapy practices, they've purchased dialysis centers, they've purchased home health companies, they have gone purchasing other basically other revenue streams, if you would, so they can keep more of the revenue created by maybe a patient's journey. So maybe the patient is seeing a physician who's in a physician practice owned by this hospital. That the patient then goes to the hospital for a procedure. That patient then goes and gets seen by home health following that. And all along the way, it's the same organization providing that care. And I think it's pitched, or at least it's discussed as and proposed that this is such a good thing for healthcare for the patient because they get a continuity of care. All of the data, the clinical documentation is available throughout the course of care for this individual. Every physician or clinician involved in this patient's care can see the full timeline of the patient's events and kind of get a good picture of what's going on. And I don't want to negate that there's some value in that. I know when I was at the Department of Veterans Affairs and we had the VA here, but we also had an Army medical hospital on base just a few minutes away, well, maybe a 20-minute drive away. And we had patients that would receive care at the VA, but then out at the base as well. It was very nice to be able to pull up our computerized patient record systems, which is what they called it at the time, and open up and see the continuity of care, not just through what this veteran had done at the VA and all the ancillary, maybe they were at a community-based outpatient center an hour away, and they saw 3 or 4 different specialties within the hospital in Augusta, and maybe they saw a physician on base. It was nice to be able to see all of that, and there was some benefit to being able to kind of you get a full picture of what's going on with the patient. But the question is that really what's driving the consolidation? And I think at least this article makes the argument, and I kind of agree with them, that that's really not the case, that it's kind of an ancillary benefit, but it is not the driving force. The driving force behind a lot of the consolidation, well, one tends to be money and revenue, but the other really tends to be just the inability of small private practices to comply with or to remain competitive in an environment where there's a lot of demands on the administration of that organization to provide maybe data, maybe manage budgets, and we'll talk about it in a little bit. So high level, I'm just going to kind of outline the few issues that they outline in this that the authors outline in this article. And they start out really by saying, look, 80% of physicians are now employed by hospitals, health systems, and corporations. Many factors have kind of contributed to this. I have some friends that are physicians that used to own a practice and then they sold to a local hospital system. And one of the things that they said was, you know what? It's nice to be able to come in and see patients and take vacation when I want to take vacation and not have to worry about payroll or managing people or the budgets for the clinic. Like all that administrative burden is gone and I can just, quote unquote, be a doctor. And I think there's some real value to that, something to it anyways, when you think about the drive to consolidation. Clinicians, and I've said this before, clinicians have gone into healthcare because they want to serve people. You know, it is very much, I know this is true talking to my grandfather who's a vascular surgeon, talking to some of my friends who are physicians, like it is very much the majority of people, or a lot of people that go into healthcare, view it more as a calling or a vocation that they happen to do to make money out of. There are, of course, there's the drive that it's a safe, secure, stable career field. There's always going to be sick people. You always have a job. There's that. But by and large, a lot of the people that go into healthcare genuinely go into healthcare because they want to be clinicians. They want to serve people. They want to treat patients, right? They don't necessarily want to be involved in the administration, in the managing of people, in the hiring and firing and running payroll and compliance and all of that, which is why like management companies have kind of built up around physician practices as well in order to kind of alleviate some of that burden. However, one of the other factors that is driving some of this consolidation, not only is it the clinicians themselves wanting to just be clinicians, and it makes sense to sell the practice and not have to do the management of the practice, but really just be a clinician. There's also the shift from fee-for-service models to more value-based payment methods, and what these models require of clinicians and clinician organizations is management of budgets. A lot of it is data compliance. Some of the things that they mention in this article in particular, again, it's called value-based payment and vanishing small independent practices. They talk about the shift from fee-for-service to value-based payment models. These payment models require clinicians to manage a budget or a spending target for a subgroup of their patients, and this can include global budget contracts like accountable care organization contracts, as well as bundled or episode-based payment models. What it boils down to is it's not just anymore. A lot of these payment models, these value-based payment models, don't involve simply the patient comes in, the clinician provides a service, provides a treatment, and then bills for that service or that treatment and gets paid for it. It now involves maybe this is the patient's 5th visit in a course of care that should maybe take 6 or 8 visits, and the physician's already been paid for these visits, and then there's maybe an incentive at the end if they get them done in less time. So it becomes more complicated, right? Not that it's right or wrong. In fact, if given the choice, I do think some of the value-based payment arrangements that we've come up with recently are more beneficial for patients than fee-for-service, because fee-for-service, I mentioned this in the book, it's right here, Better Outcomes, A Guide to Humanizing Healthcare, that the fee-for-service model of healthcare really incentivizes clinicians to bill as many billable codes as possible in the least amount of time, which typically means that you're getting mediocre or just viable healthcare services that might not necessarily be, not that they're not in the patient's best interest, but they're not the most effective, right? Because maybe the most effective treatment isn't covered. There's no code for it. You can't bill for it. And I mentioned this before on different podcast episodes. Like we, at the clinic that I run, have a couple contracts with lump sum payments. And essentially what happens is the insurance company says, listen, this is, Mr. Smith has this condition. Based off the evaluation, we'll pay you X number of dollars. You can treat them for as much or as little as you want, but you've already been paid. And sometimes oftentimes we find that those patients, we're able to do things with them in the clinic, one that we wouldn't be able to do with other patients because we don't have to worry about it being covered or not covered. We've already been paid. So if we want to do telehealth, we do telehealth. If we want to do remote patient monitoring, we can do remote patient monitoring. If we want to do some sort of, use a modality or an intervention that might not be covered by normal insurance or typically not covered by insurance, we can do that because we've already been paid, and we can do what is best for the patient, the right type of care for the right patient at the right time, and not necessarily worry about the financial repercussions. Now, on the back end, it means we need to manage those patients in a different way, right? We've already been paid for those patients, which means we need to manage their care in a way that we're not going to go into a financial deficit and go out of business treating them the way we want to treat them, right? So there's always a little give and take there. But value-based payment models put that, in a large sense, put that responsibility on the provider and not the payer. right? The payer doesn't necessarily need to worry about how much is being billed or how much is not being billed and whether this service is necessary or appropriate or whatever, because they've already, in a lot of cases, paid this lump sum or paid this episodic payment. They don't necessarily, they're not incurring additional costs. They paid once and they're done. And then there's like, we can talk more maybe later about like shared savings incentives and the like. That's a little different take on value-based arrangements. But for these episodic or global payment, global like lump sum payments, that's how it works. That now it's no longer the insurance company's job to monitor what's being billed and what's not being billed and the amount of time being spent on a patient. That's now the provider's responsibility. And that provider now needs to manage it in a way where they're able to cover their overhead, pay their clinicians, maintain profitability, and deliver quality and acceptable patient clinical outcomes. So the burden now shifts onto the private practice, in this case, to manage that. And one of the things they say in this article is that the increased cost associated with managing those types of payment models is simply too much in a lot of cases for private practices to do it and do it competitively when compared to a large healthcare system or a large corporate healthcare company that has scale and operations and maybe even the technology stack to handle that. So the demands, another thing they say in this article is, quote, the demands on smaller independent practices creates a buyer's market for corporate owners who can leverage capital, management, and scale. So again, this idea that we know value-based payment models are coming. In a lot of ways, we recognize that they need to be implemented in order to make healthcare affordable again, but in order to ensure that we're providing the most valuable service, the most effective service, I don't want to use valuable twice there, the most effective service for patients, and not be reimbursing or not reimburse clinicians for the volume of care that they're providing, but really the quality of that care, the outcomes associated with that care. So a lot of times, the large corporate healthcare companies out there have capital, meaning money, they have management, and they have scale, meaning they have a large amount of money to kind of maybe float operations while they figure something out, or just to invest in treatments and services that might be more expensive but require less treatment overall, and the like. Management, so they're involved in, they have professional managers involved. A lot of independent private practices are owned by clinicians, are managed by clinicians who didn't necessarily go to school to become managers. They don't have the training to be managers, and that has implications for the operations of the business, right? And then scale, if United Healthcare wants to buy, I don't know, some kind of maybe protective gear, masks or something like that is a good example. They can get them for $1 a mask because they're going to order 100 million of them from the supplier, as opposed to a small private practice that might only order a couple hundred, and now they're spending, $10 a mask, whatever it is. These numbers are totally made up, but you get economies of scale, not just in purchasing power, but then in the management, right? Like if you buy, or if you're a big hospital system and you have a management team in place and you buy 3 or 4 practices, you don't necessarily need all the overhead of their management teams because you've got a management team. Maybe you keep 1 or 2, district managers or regional managers to oversee the individual clinics or something like that, site managers. But the big bulk of that administrative burden then gets centralized in the mothership, if you would. And it decreases the overhead of operating the business, increases the profitability. And that's something private practices or private independently held practices can't do necessarily because they're doing it all. So there's that. Another thing, and I did think this was interesting, in the article they do discuss that directly owned independent practices are usually owned by clinicians that says they're, quote, well positioned to deliver high quality, lower cost care because evidence suggests that on average, these independent clinician owned practices exhibit lower per patient spending, fewer preventable admissions, and lower readmissions compared to hospital-owned counterparts. Physician-led ACOs have also demonstrated more savings than other types of ACOs. However, independent practices are often less equipped to participate in value-based contracts because participation requires, and this is the big thing right here, technology, infrastructure, human expertise in population health management, and relationships with delivery system segments, so like post-acute care providers. Under value-based financial incentives, these levers of control can be contained within the often risk-bearing organization, and an independent practice without such infrastructure, so without partnerships with those ancillary healthcare facilities that have been purchased by the hospital systems, they have less of ability to manage the spending and thus generate the savings or manage the quality measures for their attributed patients. So one of the big things with value-based payment models is that you might get paid some stuff up front, some money up front, but then there's either penalties or bonuses, depending on how the payer has structured it, for outcomes for maybe a specific population, a set of populations. For an orthopedic surgeon, it might be something like all the total knee replacements that you do. There's either this incentive or a penalty, if you would, for the outcomes you provide. And if you're that organization, that orthopedic surgeon, you want to have control over. You want to have control over as many areas of that patient's journey as possible, because your financial outcomes are directly tied to the outcomes of the patient, and you want to be able to ensure the quality care is delivered at each stage. So if you're an independent orthopedic practice, for example, you don't have any control over the hospital a lot of times. You don't have any control over the maybe the physical therapy clinic that you're sending this patient to, or the home health agency that you're referring the patient to, but you're still getting judged on the ultimate outcome of that patient. So sure, you could find a physical therapy clinic, for example, that you have a good relationship with, that delivers good care, and refer exclusively to them, but you don't ultimately have control over it, right? So what ends up happening is maybe something, whatever happens, something happens in this patient's care pathway that results in suboptimal outcomes, and the physicians group then looks at it and says, okay, like, we're getting dinged on this. We need to figure out a way to not get penalized or to reap the full rewards of providing high quality care. And they look to consolidate, or they look to sell into a hospital system and the like, right? So again, one of the things to quote directly from this article here, thus, intended or not intended, value-based payment models tend to favor consolidated organizations, which are more likely to have organizational capacity for data collection and monitoring, including the analytics, the reporting, and the patient engagement or outreach. And these tools facilitate guideline, co-coordinate screenings and tests. So basically, in healthcare, in value-based healthcare arrangements, all these factors go into the payment, right? Not just patient engagement and their experience, but then also the data for the clinical outcomes and healthcare spend. You need to be able to track it and display it in a way that shows that you're at least meeting the benchmarks, if not exceeding them. And big healthcare corporations can either build that out from scratch, build like custom software, or go to an expensive vendor and get it done for them, right? Pay for the integrations and all that. Large healthcare organizations are more likely to have software or backroom support to maximize the capture of, for example, diagnostic codes to boost risk-adjusted spending targets. Private practices generally don't have that ability. So, again, it's interesting to see that, I've been a big proponent of value-based reimbursement. mainly because I think that fee-for-service healthcare, like as I've said before, incentivizes just minimally acceptable healthcare quality, but it does, and it incentivizes a large volume of that minimally acceptable quality to be billed to payers, and that does not necessarily help the payers. It doesn't necessarily help the the patients receiving the care, but it helps the providers. So a lot of it, in my mind, has to do with aligning incentives, right? So I mentioned this probably in the last episode, definitely 2 episodes ago, where we were talking about UHC in particular and some of their payer models and what they do. Like, if the incentives are malaligned, like in fee-for-service, the provider is incentivized to bill as much as possible in as little time as possible. And that means that the payer is incentivized, because they're incentivized to maintain profitability, they're incentivized to cut costs. And the only real lever they have to pull in that cost cutting is to limit the amount that they pay, so decrease the amount that they reimburse, or become much more intentional and maybe scrutinous about the types of services that they cover, that they pay for. I know one of the things that I just read, I was just on LinkedIn before hitting record here. One of the things that somebody posted was like, an insurance company should never have the right to tell you what they do and don't cover. And the reality is they kind of do, because they're the ones paying, right? Like that's the contractual obligation that you have. And if you think, like, take this to the logical conclusion, if we end up saying that healthcare insurance companies should have to cover everything that is recommended or prescribed or requested or billed, they would ultimately go out of business, and then no one would have healthcare coverage, right? No one would have health insurance. So I understand that piece of things, that we want to make sure that the people that are paying, the ultimate payers of healthcare, have some say over how that money gets spent, because they're the ones spending the money, right? At the same time, however, we need to make sure that patients are receiving the care that they need, and that providers are able to provide the services that are needed by those patients in a way that's going to keep them in business. So it all comes back to aligning those incentives, and value-based payment models are one step closer to aligning those incentives. Because if you think about it, what are the big 3 stakeholders? I know there's 4 stakeholders in healthcare, but the 3 that we'll say here are directly involved, are the payer, so the insurance company, the patient receiving care, and then the provider delivering that care. What does each one of those, we'll call them the P's, what does each one of those healthcare stakeholders want? Excuse me. Well, patients obviously want to get the best quality care in the least amount of time and for the lowest cost, the lowest out-of-pocket cost to them, which means they're totally fine if the insurance company has to pay 99 or 100% of the cost. They don't want to pay as much at all. The provider wants to be able to deliver a service in a way that's financially beneficial or profitable for them, which means in the sense of fee-for-service, for example, they want to be able to bill as much as possible in the shortest amount of time, or generate as much revenue as possible in the shortest amount of time. And that incentive doesn't necessarily go away in value-based payment. We'll discuss in a minute. The payers, the insurance companies, want to, again, they want to maintain profitability, but they want to be able to keep their constituents, their members, happy. So provide the services required to maintain their membership levels in a way that does not result in a financial loss, right? So they're trying to decrease the cost. They're ultimately, the largest payer in healthcare ultimately is trying to limit the cost, because their profitability rests on their outlay, right? Their capital outlay. So if you look at those three individuals, those 3 stakeholders or members in the healthcare ecosystem, and their incentives, what they want, let's take a look at each payer model. So in fee-for-service, for example, there is no guaranteed revenue for the provider other than what they bill for, right? and it's maybe it's episodic, right? This patient comes in for this visit, and the only revenue I'm going to get for this patient is for this visit, unless they come back again and again and again. So they are then incentivized to provide services, to bill as many billable codes as possible within that patient's allotted appointment time, and hopefully in a way that encourages that patient to come back again and again and again. Maybe it means they take a treatment or choose a treatment or a treatment protocol that requires multiple subsequent visits. I would not say that that's like usually the case. Clinicians generally are not prescribing treatments based off of the amount of money they'll make on them. That's not generally what most do. Sure, there's a bad apple here and there that does it, but really the idea is you're trying to provide the service in a way that's profitable in this one visit, because this episode is all you're going to get unless the patient shows up again. The patient, if there's a copay involved or coinsurance involved, wants to do the least of that, right? They want to spend the lowest out of pocket that they can for the fewest amount of visits, or the fewest amount of treatments required. And then the payer is also in the boat of wanting to spend the least amount of money. So you have on these spectrums here, and sometimes the patient might have a couple different incentives here, but they want to get better, and they want to get better as fast as they can, right? So sometimes they don't care if it's going to be a little more expensive up front if they know they're going to be done tomorrow instead of 3 months from now. So there is that kind of change in dynamic. But essentially you've got the payer who's trying to limit the overall cost in healthcare, the provider or the patient who wants to receive the outcomes as quickly as possible for the least amount of out-of-pocket expenses themselves a lot of times, and then the provider who's incentivized to maximize their billable productivity for each encounter, because that's the only guaranteed revenue they're going to get for this patient. Look at something like a global or episodic fee for service model where, the payer says, Rafi, you're going to treat Mr. Smith and you're going to get $1,100 for him. Treat him as much or as little as you want. Well, what has that done from an incentive standpoint? On one stand, for the provider side, it's totally taken away the guaranteed revenue worry and the incentive to bill as much as possible, because they've already been paid. The provider's already been paid. They don't gain anything else by stretching out treatment longer than it needs to be, by billing more or padding visits with codes that might not necessarily be necessary or beneficial. And they're incentivized then to get the patient better, to close them out and discharge them, if you would, in as little time as possible, because they've already been paid for the entirety of the care of service. So if they can do it in 2 visits instead of 4 visits, they've saved the overhead of those 2 additional visits, and that goes right to their bottom line. And that lines up perfectly with the patient's incentives, or what their goals are, is to get better, or to achieve whatever outcome it is in as little time as possible, with as little out-of-pocket costs as possible. So when you move into something like a value-based payment model like that, like global sum or global lump sum payment models and things like that, it begins to align all of the incentives. Now, sure, there are things that need to be ironed out for sure in that arrangement. I've said it before, like the payers probably have a little bit too much say, or a little bit too stingy in what they would consider an appropriate global service fee. Like, you could always do some more work there. But a lot of it has to do with the data that they're seeing, right? And the data upon which we're making the decisions, which is one of the challenges that we see in implementing value-based care, is that these benchmarks are set a lot of times on data that is provided by organizations who operate primarily in a fee-for-service model, right? So, for example, like a total knee replacement physical therapy, national benchmark, let's say, is 16 visits or something like that. Making it up, it probably is in and around that area, though. But that 16 visits is based off of a physical therapy practice whose majority, 99% of their caseload, is fee-for-service. Would that change, or will that change over time? I don't know. We don't have the data to suggest one way or the other. But it's an interesting thing to think about. So anyways, what does this mean for independent private practices? Well, obviously it means that you can begin to see that in order to effectively and profitably and sustainably implement value-based payment models in a practice requires software. It requires data analytics capabilities. In some large cases, like hospital system or where you're dealing with specific diagnostic types or diagnoses, like population health, we've talked about the social determinants of health before a couple times on the podcast. Like those begin to become a much more important and involved part of this patient's care. All of these, coordinating all of these different pieces is very expensive on one end, but just simply not possible if you're an independent practice, right? If you're just a private physical therapy clinic, for example, or even a physician's group, for example, you don't necessarily have control. You don't have control over where your patients go to the hospital, where the physician that they see, the other providers that are involved in your patient's care. So it means you have a whole lot less control over the outcomes, which means you might get penalized, you might not reap the full benefits, you might end up losing money in the long run, trying to deliver services in a value-based system when you have such a small sphere of influence. However, the large continuous growth of healthcare corporations, just from like an emotional standpoint, I try not to make decisions emotionally. We should not try to make policy emotionally. But it is definitely in the forefront a lot of the conversations in healthcare these days. Is like, it just feels icky to have this big corporate company telling me what I can and can't have as far as treatment goes. What if this pill is a requirement to keep me alive and the insurance company won't pay for it, all of that kind of stuff. So going back to this article here on vanishing independent practices or small independent practices, let's see here. So, for example, insurances, retail chains, and private equity firms, we've talked about that before on the show, have rapidly acquired or affiliated with provider groups expressly to participate in value-based contracts. For example, United Health's Optum is a market leader in value-based contracting with nearly 5 million people in such arrangements. Humana is the largest provider of primary care focused on older adults. These practices have been popping up all over the place. They partner with a private equity firm to build a risk-based primary care practice all over the country. And then last year, CVS Health purchased the Medicare Advantage-focused primary care chain Oak Street Health and plans to scale these practices nationwide. So the drive for some of this consolidation is value-based payments, because they understand if we can control more of the care pathway, we have a better chance of in a real sense, providing real value. You know, I mentioned this before on a few episodes, and I've caught a lot of flack for this over the last year. Like, is that necessarily a bad thing? Is it necessarily a bad thing that, you know, CVS now operates Oak Street Health and they're managing care in a way that is more cost effective and arguably, I mean, I have not dug into any of the clinical outcomes, clinical data, so don't quote me on this, but arguably the same, if not better, clinical outcomes as another private practice. Is that a bad thing? Maybe. You know, I think there's a value decision or priority decision to be made there, because some of these large chains do have a very, we're not going to say mill or cookie cutter way of operating, cattle herding, you know, trying to get as many patients through as possible. And there are patients, so one of the major end users, recipients of healthcare services, like that personal individualized relationship that is healthcare. So you can say that is lost in some of the big healthcare expansion. But I would almost say that in some senses, private practices are really enabled by some of these large healthcare companies because they subsidize some of the care, right? Um, so it's not as simple. All that is to say is not as simple as saying big healthcare is evil, big healthcare is not evil. But it is something to be aware of from a policy standpoint, from a healthcare decision-making standpoint. When you're choosing a private practice or choosing a provider, independent private practices versus large hospital systems and the like. So, anyways, that's a big foray into value-based care, but it's driving a lot of times these consolidations into large healthcare organizations. So what does that mean for private practice? Like, here's the crux of it. What does it mean for small, independent private practices? Does it mean they're going away? Does it mean they're going out of business? How can they stick around? What are the ways that they can remain viable in this environment? Because we are moving towards value-based care, where they need a lot of back office support, where they need some data management, they need some ways to display and analyze data to prove their value, to show they're meeting benchmarks and all of that. I think, in my mind, I can think of a couple different ways that this happens, where practices are able to maintain their independence, to maintain their individual patient care relationships, and not have to sell to a corporate organization. The first one of these that comes to mind, and we've explored this a little bit at the clinic, is like provider networks, where you have a network that contracts with the payers, maybe Blue Cross Blue Shield, maybe Aetna or something like that, and procure some of these value-based contracts. And then the member practices join the network. Everything gets billed under the network's contract, but the entities remain independent and remain independent. They're not consolidating at an organizational level. So, and from a practice management standpoint, and data management standpoint, then the network, whoever's managing the network, ends up making these requests for data from the individual providers, consolidates that data, and then submits that to the payers for whatever reporting is required for these value-based arrangements. And that can be a very viable way of doing it. And one of the things that it has the potential to do is it has the potential to get the effect of a large hospital system without creating a large hospital system. What I mean by that is the next option that I was going to mention is like an MSO or managed service organization tends to be all one discipline. Like an MSO tends to be all the physical therapists in Georgia get together or something like that. A provider network can get and incorporate the various disciplines. So you could get an orthopedic surgeon in the provider network. You could get a primary care physician or primary care provider in the organization. You get a physical therapist, occupational therapist. You could get a home health company. You could get home nursing, whatever. You could get this conglomerate of clinical disciplines and clinical organizations all in the network, so that they're able to participate in these value-based care arrangements in a way that doesn't require that they all lose their autonomy. You know, the orthopedic surgeon wants to remain in charge of their practice and their staff and do provide care the way they want to. The physical therapist does the same thing, but it does two things for those individual practices. One, it gives them access to those value-based payment structures, which they wouldn't necessarily have access to otherwise, which means they can get shared savings incentives, they can get all the lump sums, all of that, so they could potentially reap some real financial benefits, financial rewards for the value they're creating in healthcare. But then also, a rising tide lifts all ships. So maybe it allows an up-and-coming physical therapy clinic, for example, to establish relationships with other referral partners in the network. And because we're holding each other accountable from the data and the outcomes, the service that I deliver to these patients as this physical therapy clinic, I know is going to have to be on par, if not better than the competition. One, because we're all incentivized to provide this quality care, But then also, if I know I nail it, then all these other provider organizations in the network are going to like feed into me, right? So you can build really robust referral partnerships and referral relationships based off of that network, which is, again, it's like a win-win-win-win. The patients are winning because they're being handled in a value-based way, but they're still maintaining their individual relationships with individual clinicians. The organizations themselves, the provider organizations, are able to reap the financial benefits of being involved in value-based arrangements without necessarily having to sell their soul to corporate America. That sounded negative. Sorry about that. Without having to lose their autonomy as clinicians. And the payers benefit because they're hopefully managing the population, managing their membership's health in a way that is financially viable and providing the services that really are indicated for these patients. So that's like top of the list in my mind, thinking about how does this work. That's definitely one of them. The other would be like a managed service organization or an MSO. And a lot of times these can be equity holding organizations or they can be independent, but essentially they do the same thing or a similar thing, only with a specific discipline. So like all the physical therapists could be in an MSO. That MSO could then go to the payers and try to negotiate value-based payment arrangements based off of just the volume of visits and the population that's covered and all of that. It still falls short, though, however, because it's only one discipline. It's only one leg in that stool, if you would, of the care. You don't have a lot of control over the physicians, the hospitals, the other care providers. But you can offload some of that administrative burden and costs as well, which is why a lot of organizations do go the MSO route, because you're consolidating, centralizing a lot of the administration of those practices, which keeps you financially viable. The other, and this is the last point I'll make, how independent practices stick around, if you would, in the world of value-based care is really to leverage technology. And I know that this is a podcast about exploring the possibilities of new healthcare. I work a lot in healthcare tech. I consult with and work with a lot of healthcare technology startups that are looking to empower a value-based care. This is not a pitch for them in any way. It's just a practical thing. I've said this before, that healthcare technology, artificial intelligence, data analytics, whatever you want to call it, I don't care. The technology and the tools that are being developed today are going to allow clinicians to spend more time being human and individualizing the healthcare process while alleviating a lot of the administrative burden of delivering that care. Whether it be clinical decision-making aids, whether it be data tracking and analytics tools that allow you to tap into some of those data sources for value-based, the requirements for value-based reimbursement, whatever it is, that technology is making that type of work less costly. And that savings is going to go, hopefully, pass through the provider organization at some level, but then ultimately make it to the patient. So anyways, I know that was a long discussion. We're at 45 minutes. We're going to wrap it up now. About consolidation in healthcare and value-based payments, and do value-based payments crush or kill independent private practices? I think if something does not change, the answer is going to be, unfortunately, yes. Now, I'm very hopeful. I'm an eternal optimist, to quote a former colleague of mine. And I do think that provider organizations, independent private practices, are going to become more creative. They're going to become more innovative and adopt more technology and tools in order to enable them to stay viable and competitive in the market. Because I think at this point in the game, we all know that something needs to change in healthcare. We need to get away from fee-for-service. We do need to move more towards paying for outcomes and for quality and not for the volume of care being provided. And where there's a need, there's a way, right? Necessity is the mother of all invention. And I think there's going to be a lot of really, really cool advancements aimed specifically at this independent private healthcare practice market to enable them to maintain profitability, to deliver high quality care, and to participate in some of these value-based services. So that's my ending on a positive note. So hopefully you found this discussion, if nothing else, kind of prompted you to think and maybe go read a little bit more about value-based payment models and what it entails. I know that I've been a proponent of value-based payment model for years and years, and it wasn't until recently, probably in the last couple of years, where I really began to think about what it means for private practice and whether or not the move to value-based care is going to be something that private practices are going to be able to do or not. So anyways, the title of the article, and I'll link to it again in the show notes, is from the Journal of the American Medical Association, August of 2024. And the title is Value-Based Payment and Vanishing Small Independent Practices. You can go read that. It's a very quick read. It's like an opinion article. But then they've got 10, 11 references here of some peer-reviewed journals. So it's worth reading. It prompted in my mind this thought, this discussion. And I'll, again, link to it in the show notes. So you can go find it and read it. And let me know your thoughts. Shoot me an email if you think, if I missed something, if you disagree, if you want to have a discussion, shoot me an email, info@rehabupracticesolutions.com. If you like the show, head on over to iTunes, leave us a rating and review. Helps people find the show. If you want to get notified when we drop new episodes, which tend to be every other Wednesday, go to www.betteroutcomes.show, sign up there, listen to all the backlog of episodes. If you want to hire me to speak at your organization, we have set up a page for that. It's speaking.rafisalazar.com. And if you run a healthcare organization, a company, and you're looking to differentiate yourself from the competition, to create a value proposition that's going to drive business in the form of qualified leads entering your sales funnel, check out the Positioning Alignment Workshop, the Healthcare Positioning Alignment Workshop. You can find that at positioning.rehabupracticesolutions.com. That's positioning.rehabupracticesolutions.com. Until the next time, folks, be safe, be healthy. I will talk to you then.